first mechanical circulatory device, that is IABP. IABP is nothing but it is called as intra-aortic balloon pump. So intra-aortic balloon pump is nothing but this is kept. So this has two balloons usually, or two tubes to be defined as properly. Okay. So it was introduced in 1960s. It has a dual lumen. So it has dual lumen catheter where one lumen is used for aspirations or injections, and the other lumen is used as a balloon. Is used as a balloon here. So the balloon, what is the property is that you can see here the balloon, what we do is usually we keep it. So this is the arch of aorta. So you can see here. So this is aorta and this is the arch of aorta. So this is your left subclavian artery and this is left common carotid artery and this is right brachiocephalic artery. Usually the balloon pump is kept sent from the right femoral artery and it is kept near just below to the left subclavian artery. Why? Because if you keep the balloon above the left subclavian artery, whenever this balloon gets inflated, the left circumflex artery may get compressed or obliterated and there could be decreased perfusion to left arm. So how does IABP work is that this IABP is usually it inflates during diastole, inflates in diastole. So as we all know that coronary perfusion is maintained during diastole. So now if it inflates during diastole, the balloon, what will happen is that it sends the blood back into this direction. So during diastole, the blood is going now back to this direction and it goes into the coronary arteries and thus helps in coronary perfusion because there is no chance that this blood can go in this direction because the balloon is completely inflated. So this diastolic inflation will lead to what is called as increases in diastolic blood pressure, and there is diastolic augmentation. So this increase in diastolic blood pressure will help in what is called as increase in coronary perfusion. Similarly, during systole, what will happen? So it is inflating during diastole and deflates during systole. So whenever there is deflation of this balloon during systole, also there will be elastic recoil of the aorta. So what will happen whenever this is suddenly getting close? There will be elastic recoil and this aorta will get stretched. This stretching of the aorta during this collapse of this balloon will lead to what is called as decrease in afterload. That means that the vessel has completely opened now. So the vessel is getting open now. So what will happen is that the left ventricle can easily empty the blood because the afterload is very much reduced. So thus IABP helps in increasing the coronary perfusion. Also, it decreases the afterload. Since it's decreasing the afterload now, it helps in increasing the cardiac output because the left ventricle now have a less resistance. So afterload means nothing but peripheral vascular resistance. So peripheral vascular resistance is decreased. So left ventricle can easily empty now without much resistance from the aorta and thus it increases the cardiac output. So cardiac output increases by how much? Usually they say that it increases the cardiac output by 300 to 500 ml. So you can see here in this patient, generally the intra-aortic balloon pump usually is synced with the ECG and it inflates during diastolic phase, that is from the T wave to P wave. You can see here there is diastolic augmentation and increases the coronary perfusion. So this is the systole part. This is the usual diastolic part and there is diastolic. You can see here the diastolic notch is now getting augmented here. So what are the indications for IABP is that IABP can be given in patients of cardiogenic shock from any cause whatsoever it may be. Patient with geoparatized myocardium which is at risk. You can bridge to another assist device. Suppose you are planning for any other mechanical circulatory device. Till then you want to keep the patient on a mechanical support device to support it. You can ask as a bridge. Suppose patient has unstable angina, which is refractory to medical therapy. So why we are going to use in these patients is that suppose patient is unstable angina and the pain is not getting subsided. And as we all know that IABP increases the coronary perfusion, and thus this can be used to relieve the angina as well. Also, patients have unstable ventricular arrhythmias because it increases the coronary perfusion and decreases the load on the heart as well. Also, high risk PCI in setting of severely depressed LV function and high risk PCI involving unprotected left main. So, all these patients you have to use IABP, you can use that. So, this is not compulsory. Only indication which is compulsory, they say, is now is cardiogenic shock. This is also a class 2B recommendation, and remaining all the indications you can use it just to support or for the hemodynamic support, but this is not mandatory. So what are the contraindications to use of IABP? Most important is the aortic regurgitation. Why? Because as we all know that suppose this is there, I'll tell you 1 minute. So we know that suppose the valve, so this is the valve, and in aortic regurgitation, already there is a backflow of blood during diastole from the aorta to the left ventricle. So increased flow is going to the left ventricle here. So this is called as aortic regurgitation. Now, if you increase the diastolic augmentation, if you do, so this balloon also gets inflated during diastole and sends blood back into here. So there will be increase in severity of AR if you put in patients of moderate to severe AR. If you put a IABP, AR severity will increase and patient may suddenly land into hemodynamic compromise or LV failure. So it should not be used. Suppose another contraindication is that suppose a patient has aortic dissection, if you inflate that, there can actually increase the dissection. So in dissection patients, or suppose a patient has a very active infection of there, so you have to avoid in those cases. So dissection is the main contraindication. Aortic valve insufficiency, previous aortic stenting, these are all causes absolute contraindications. Whereas relative contraindications is severe atherosclerosis. Suppose patient has coagulopathy disorders or severe sepsis, then only here it should be remembered that only patient of severe sepsis is a contraindication. Sepsis itself is not a contraindication for IABP placement. And cardiac output is usually increased by 0.3 to 0.5 liters, as we have discussed, that is 300 to 500 ml per minute. So how do you choose the size of IABP? Is that balloon sizing is based predominantly on basis of patient's height. You have to choose it based on the patient height. Usually the sheath which we use is the 7 to 8 French sheath is usually used. And balloon can also be inserted sheathless. There is also option that without sheath also you can do that. So based on patient height, that is 147 to 162 centimeter IABP volume, you can select the size based on that. So important thing to remember is that the balloon tip should be placed at the proximal descending aorta, and it should be below the origin of left subclavian artery. So as we have said that it should be below the left subclavian artery and it should be above the renal arteries. Why? Because if it is coming above and covering this left subclavian artery, the supply to the left arm can be compromised and patient can land up into gangrene or ischemia of the upper limb. Or similarly, if it is covering the renal arteries, then what will happen is that it will inflate the renal arteries and there will be decrease in renal perfusion. Decrease renal perfusion and patient may land into acute kidney injury or kidney failure. So you have to look after that position. That's why we usually use fluoroscopy to look that. Also, it can be done under bedside as well if fluoroscopy is not available. So you can just measure the size from the left infraclavicular vein. That is the left infraclavicular space, and from up to the sheath you can take the measurement and then you can put it accordingly, and you can follow up then in chest X-ray. So you can see here, so chest X-ray, the lead is kept here. This is the lead you can see here. So this lead is below the origin of the subclavian artery. And you can see in some other patient, if there is misplacement of that, the lead is actually visible in this part. Here also you can see that the lead is very much lower. So the arch of aorta is usually in this direction. So subclavian artery is usually expected to come from here. The lead is very much down. So you can reposition the patient based on this X-ray. So bedside X-rays are very important if you are planning for a bedside IABP. Previously, the IABP was having a class 1 indication in 2004 STEMI guidelines. Later on, after the shock 2 trial, which randomized acute MI and cardiogenic patients to either IABP or no IABP, and it shows that there was no much difference in outcome, and the guidelines has then given a class 2 recommendation in 2013. So this was the IABP shock 2 trial, which was published in NAJM in October 4, 2012. So where they took 600 patients with cardiogenic shock was taken, who was having acute myocardial infarction, and half of the patient they put IABP, and remaining half was having no IABP. And primary efficacy endpoint you tried to measure was 30-day all-cause mortality. So conclusion, they showed that use of IABP did not significantly reduce mortality. So there was no benefit in the mortality they found, and thus the recommendation was reduced. So current recommendation says that immediate PCI is routine IABP is usually not indicated in patients. So only if it is indicated like cardiogenic shock, then only you should use that. So anticoagulation for IABP patient, you should do anticoagulation with heparin to reduce the chances of thrombus formation because the vessel itself. So suppose this is the aorta and you have a plastic here, always it can be thrombogenic. So you should give anticoagulation with heparin. Weaning of IABP, here IABP usually you have settings like 1:1 cardiac cycle, that is 1:1, 1:2, or 1:3. So what do you mean by that? That if every cardiac cycle is to be stimulated, you keep that as 1:1. If it is every alternate, then 1:2. That means every second cycle will be having a diastolic augmentation, and 1:3 if only every third beat will be having a diastolic augmentation. So patients are usually kept on 1:1, and whenever we are trying to wean, you have to decrease it to 1:2 and then to 1:3 to see how the patient is responding. So generally, if a patient has tolerated augmentation at 1:3 for an hour, you can discontinue the IABP. So that means that if a patient have the shock has got better or got relieved, and now patient is on 1:3 and it is tolerating the IABP for at least an hour, you can actually plan for IABP removal.